Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. This episode features a discussion on KIT-targeted therapies in the treatment of advanced systemic mastocytosis. It is part of a larger educational program entitled The New Paradigm of Precision Medicine for the Management of Advanced Systemic Mastocytosis. During this podcast, Dr. Prithviraj Bose from the MD Anderson Cancer Center will lead a multidisciplinary panel discussion with Caitlin Rausch, a pharmacist also from the MD Anderson Cancer Center, and Ilene Galinsky, a nurse practitioner at the Dana-Farber Cancer Institute. Their discussion topics include diagnosing advanced systemic mastocytosis, clinical trial data on avapritinib and midostaurin, and how to monitor for and manage toxicities associated with these therapies. For more information on our expert panel, along with a link to the complete program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say on this important topic.
Hi, this is Prithviraj Bose. I'm one of the leukemia faculty at MD Anderson Cancer Center in Houston, Texas. Welcome to this podcast on advanced systemic mastocytosis. I have the pleasure of being joined today by Caitlin Rausch, one of our leukemia pharmacists here at MD Anderson.
Hi, everyone. This is Caitlin here at MD Anderson with Dr. Bose and Ilene.
Hi, this is Ilene Galinsky. I'm nurse practitioner at the Dana-Farber, joining the podcast today.
Thank you, Caitlin and Ilene. So I'll get us started with an overview, a quick overview of what can be a challenging and somewhat difficult entity, and not made any easier by the fact that it is a rare condition, of course. So systemic mastocytosis is a clonal proliferation of mast cells, which can be multisystemic and usually is multi-organ, I should say. And the pathologic diagnosis relies on several criteria. You need a major criterion and at least one minor criterion to be fulfilled. And if the major criterion is not fulfilled, 3 or more minor criteria can suffice to make the WHO diagnosis. Again, this is a pathologic diagnosis, so I won't dwell on the details, but essentially what you're looking for is these multifocal dense infiltrates or aggregates of mast cells in the bone marrow or in any other extracutaneous organ. To distinguish this from cutaneous mastocytosis, we've got to find it in the bone marrow or in some other extracutaneous organ. So that's really the major criterion. And then the minor criteria have to do with, one, the appearance or the morphology, the shape of these mast cells, with at least a quarter having to be spindled or atypical in morphology to satisfy one of the minor criteria. The other 3 minor criteria being somewhat more objective, with tryptase over 20 being one, and then a KIT mutation, usually an exon 17 D816V being another, and then the aberrant expression of CD25 plus or minus CD2 on the mast cells being the other minor criterion. So again, one major, or I should say the major criterion, and at least one minor criterion will suffice to make the diagnosis, or 3 or more minor criteria without the major criterion. Now, where it gets a little bit more challenging and where it's really the clinician as opposed to the pathologist that has to make some important distinctions is in categorizing patients into indolent, smoldering, and advanced systemic mastocytosis. Indolent SM is by far the most common, and this is the hallmark of this is the lack of organ damage. So there are no so-called C findings, C standing for consider cytoreduction. Again, there should be no C findings in patients with indolent or smoldering systemic mastocytosis. In other words, there is no organ damage from the infiltrating mast cells. So C finding is a hallmark of advanced disease. Now, the distinction between indolent and smoldering systemic mastocytosis, smoldering is really very rare, is that while neither is characterized by C findings, one can have some B findings. So in indolent SM, one can have 0 to 1 B finding. And then in smoldering SM, one can have 2 or more B findings, but no C findings. So what do we mean by B findings? So B findings, again, are features of mast cell infiltration or a high burden, but without causing organ damage. And of course, these are outlined in the criteria. There are certain exact features that we look for. For example, the C findings typically have to do with cytopenias, hypersplenism, an enlarged liver with liver function abnormalities, destructive lytic bone lesions, ascites, weight loss, malabsorption, and things of that nature. Finally, just a word about prognosis. Happily, indolent SM has a very good prognosis. Survival is normal or near normal, a 5 to 10% chance of progression of indolent SM to more advanced forms. Again, this is the most common subtype. Smoldering SM is very, very rare. The prognosis is not well defined, but advanced SM, unfortunately, has a markedly shortened survival. And within advanced SM, we talk about mast cell leukemia, which typically has the worst survival in the order of months in one series. And then we have SM with an associated hematologic neoplasm, or SMAHN, which is the most common form of advanced SM. Survival for that entity has been reported in the range of 2 years, although more recent studies have put it at a slightly higher number than that. But then there is aggressive SM as well, which is the other entity under the advanced SM category. And median survival for that has been reported around 3.5 years. Again, these numbers are from a somewhat older Mayo Clinic study, and we have a larger study now from the ECNM that puts these numbers in all three entities at a slightly higher duration of median survival. So again, aggressive SM, SMAHN, and MCL make up the three types of advanced SM, by far the most common being SMAHN. Now, with that overview, I wanted to open it up. It's interesting, the three of us, of course, are from two major cancer centers, but one important distinction perhaps is that we at MD Anderson are at a standalone cancer center, whereas up in Boston at DFCI, they are in a more integrated system within, of course, a multi-specialty setting and perhaps access to some other specialties as well. For example, we don't have our own allergists here, and our referral patterns might vary slightly. So very interested here in getting Eileen's thoughts about who are these patients that you're seeing, who's referring them, what are your referral patterns?
Thank you for that overview. It was very helpful. So we get a mixture. We are lucky that we have a strong allergy service here that can see a lot of these patients and then refer them to us. Especially, I had read somewhere, and I just learned this, I thought was interesting, that people that have anaphylaxis to bees or hornets are at an increased risk for having mastocytosis. So we've been aware of that. So for people that go to ERs for anaphylaxis, it's something to think about down the road. But we get referred from our allergists. We get referred from primary care, as well as a lot of these patients have GI symptoms. So they've been to having various GI workup that they can't find a reason for their GI symptoms. Some of them have now been more keen, and when they do biopsies, they have been biopsying and looking for tryptase and staining it for the KIT mutation. And then we've been participating in the clinical trials. We also get people from all over who have had this diagnosis and just feel helpless with the current regimens prior to the approval of avapritinib and are looking for alternatives. As you mentioned, people's lives can be pretty miserable in the advanced SM patients, and so they're looking for anything to make their quality of life better.
Absolutely, absolutely. And yes, it's interesting. We actually do not have our own allergists, like I was saying earlier, so our referral patterns are a little different. What I see the most is actually referral from other hemoncs who perhaps may not be as comfortable with this rare entity and prefer to refer them to us. We occasionally will get referrals from outside allergists as well, sometimes for clinical trials and newer agents like avapritinib. And another thing is, and Ilene, you probably see some of this, some of them end up having MCAS or maybe HAT. We, again, do not see those diagnoses, but do you do some of that?
Yeah, most of the activation, we see a handful of them, but we tend to send them mostly after we may see them once. We send them back to our allergy team.
Right. That's actually similar to what we do as well, except that we are sending them out to outside allergists. All right, great. So let's start with our cases, Ilene. Why don't you get us started with your first case?
Okay. I'm going to present two cases today. I would like to talk about them after. This is a typical presentation. The first patient is a 75-year-old gentleman who had a 3-month history of fatigue and abdominal distension and lower extremity edema. These symptoms were becoming pronounced while he was going through a steroid taper, because prior to that, he had these vague symptoms of not feeling well, having pruritus. So his local doctor had put him on steroids. When we saw him, he had a white blood cell count of 27,000, hemoglobin of 8.2, a platelet count of 64. His differential showed 76% polys, 9% bands, 8% lymphs, 3% monos, and 1 nucleated red blood cell. He had some scans done prior to seeing us, and they showed a pleural effusion, some ascites, splenomegaly, and he came to us. And so one thing we should talk about is what should you do as part of a workup of somebody with these symptoms. He had previously had some scans done, including an endoscopy, and they were all negative. However, the biopsies weren't sent for special staining to look for mast cells. As mentioned earlier, this is not a common disease, so I don't think people think about adding these things. We added a tryptase, and of course it was elevated to 187. And we did a bone marrow exam that was hypercellular marrow. It did show 40% mast cells. And by flow, it expressed CD117, aberrant CD2, and CD25. Cytogenetics were normal. Our molecular sequencing panel was positive for KIT D816V, and his other mutational abnormalities were an SRSF2, TET2, and a CUX1. So we made the diagnosis of systemic mastocytosis with an AHN history based on his marrow and molecular makeup. His treatment, we had the avapritinib trial open, and we proceeded to place him on that trial. Interestingly, he was started at a dose of 100 milligrams per day, and after 2 months, his mast cells in his marrow went from greater than 40% right down to 10 to 15%. And after 1 year, his bone marrow study showed a rare mast cell. So he was in a complete remission. This gentleman had absolutely no side effects on the avapritinib. It was tolerating it very well. Unfortunately, at the 2-year mark of the clinical trial, when he came for his Q3 month visit, he had 2% peripheral blast, and he was pancytopenic. And we did a marrow at that time, and the marrow showed greater than 20% blast compatible with AML. Interestingly, his marrow showed no mast cell disease at all. He received a couple cycles of Vidasa and venetoclax, and he died of his AML. Being that he was on the clinical trial and there's no data to treat the mastocytosis along with the myeloid malignancy, we removed him from trial and he did not receive further avapritinib. I would like to open up discussion to the group, what their thoughts are on such a patient.
Absolutely, Eileen. Tremendous case. This is a really good case. I mean, it makes a number of important points. So, first of all, I will say that, your patient had fairly non-specific symptoms at presentation, and thinking of SM right there is one of the most important take-home points from such a case. Obviously, the tryptase, which was really high, was a tip-off, but ordering the tryptase in the first place requires thinking about SM. And of course, SMAHN, unfortunately, is the most common subtype of advanced SM. So it presents two problems. We have the mast cell problem and the non-mast cell component as well to manage in your patient, as has been shown in long-term follow-up from the Explorer trial at this past ASH annual meeting 2021. The progressions are often in the non-mast cell component, with the SM still remaining in remission, just as you said. Fortunately, the other component can just take off. And in this unfortunate case, the patient developed AML. And one thought behind this is that the KIT mutation, which drives the SM, may also drive the AHN. It has been shown to be present in multiple lineages, not just the mast cell lineage. And so I guess this is exactly in line what we have seen on the Explorer trial. Now, on the topic of treatment, before we get into some detail about all the drugs, and pull Caitlin into that conversation, get her thoughts on the toxicities, the pharmacology, and all that, let me just quickly go over the response rates and the options we have. So, as Eileen mentioned, avapritinib was just recently approved, June 16th, 2021. Prior to that was midostaurin. Those are the two approved agents for advanced SM. Now, and we've also all seen cladribine used and used it occasionally. Cladribine is also an effective agent. I have personally not used interferon, but in advanced SM specifically, I think I would reach more for one of the KIT-targeted agents, or maybe cladribine in some situations where a very quick response may be desired. But just to give the sort of the top line results, with cladribine using the old criteria known as the Valent criteria, the response rate was about 50%. And with midostaurin, this was approved almost around 5 years ago now, the response rate was 60%, again using the modified Valent criteria. Now, the avapritinib is a different drug in the sense that it is highly specific and selective and potent against mutant KIT, relatively sparing wild-type KIT. It was specifically developed to home in on the mutated KIT. And the response rates to avapritinib in the Explorer and Pathfinder trials, the phase 1 and 2, were both 75%. Now, very critical to point out that the criteria are actually pretty different. I just said that for midostaurin, the response rate was 60, and I said that for avapritinib, it was 75, but the criteria are very different. Avapritinib used the International Working Group, the modified IWG criteria, as it is called. And just to give a perspective, there was some post hoc analyses done by the EMA of the midostaurin data using the same criteria, the modified IWG criteria, which are the more modern criteria. And so comparing apples to apples, you have a 75% response rate for avapritinib using these criteria. But when you use that for midostaurin, it drops to 28. It's not 60. So the criteria make a huge difference here. Just wanted to put that out there. And then, of course, a lot of toxicities, and we'll come to that. And there were a couple of abstracts this year at ASH, this past year at ASH, one of which I already mentioned, that was to do with the progression of patients on the Explorer trial really being in the non-mast cell component, while the SM stayed in remission. And then there was also an interesting abstract showing that by about 6 cycles of avapritinib, the morphology in the bone marrow, as well as the aberrant immunophenotype, mostly returned to normal. That was really impressive.
Absolutely.
Ilene, why don't you do your second case and then we can discuss both the approved drugs.
Awesome. Thank you for that. So my second case is a complicated case. Just want to go back a bit on her history. While she was a child, she was diagnosed with skin pigmentation changes, and she achieved the diagnosis of urticaria pigmentosa. And this got worse, and her pruritus along with it got worse when she was exposed to the sun. As she got older, she noticed she had flushing with drinking alcohol and had flushing and abdominal discomfort if she took any aspirin. At age 40, her pruritus was affecting her quality of life. She also now developed chronic diarrhea, abdominal bloating. She did not have any pain. She did develop lymphadenopathy with neck nodes. These were biopsied at the age of 40, and they were c-KIT positive. And she was diagnosed at that time with a mast cell disorder, and she had a tryptase about 517. Now, this was pre-midostaurin trials, so we're going back a couple of years. For the GI symptoms, she was started on gastrocam and H1 and H2 histamine blockade, and we'll talk about that after the case. She then started to develop mild pancytopenia, and she had a marrow done, which revealed systemic mast cell disease. At that time, she was placed on Hydrea and Gleevec. Surprisingly, the Gleevec, as you can imagine, would not work in a disease that was D816V positive like hers was. She started to progress to the point that she could not eat and required central line for TPN. She was actually going to be going onto hospice when we saw her at the age of 46. When we saw her, her tryptase was 774, and she had a histamine level of 4,777. Her CT scan showed ascites, hepatosplenomegaly. She had an EGD that showed esophageal varices, gastric erythema, and duodenal nodules. Colonoscopy showed pancolonic edema. Liver biopsy showed an elevated hepatic pressure gradient, and her bone marrow showed greater than 30% cellularity of her mast cells. So she was started on midostaurin at that time, and she was on the trial for 12 years, actually. When we started, she was on TPN. After 3 months of therapy on midostaurin, she was weaned off. Her GI symptoms resolved. After 12 years, she progressed on midostaurin and then transitioned to avapritinib. She remains in a PR after 20 months of therapy. And I wanted to just review when she started on avapritinib. One of the common side effects we see with patients on avapritinib is this brain fog. Her starting dose was 200 milligrams per day. She was decreased to 100 milligrams for cognitive dysfunction, and then it reoccurred despite the 100 milligram dose mod to 50 milligrams. A year later, at the 50 milligrams, we tried to re-challenge her, but her symptoms of brain fog came back, and she had difficulty with memory recall, and her cognitive dysfunction, it didn't get as severe as on the higher doses, but it did return. So at the 50 milligram daily dose, where she continues, she has no further issues of her cognitive decline. And she was here last month to begin cycle 40 on therapy with a normal blood count and partial, she says, has a slight tryptase seen on her bone marrow test. But otherwise, she's doing fantastically well.
Well, that's an exceptionally gratifying case, isn't it?
It is, very much so.
So maybe Caitlin and Ilene, you guys can take it from here with the with the discussion of both the drugs.
So both the medications, avapritinib and midostaurin, there are some overlapping toxicities, particularly the cytopenias, thrombocytopenia. These patients can also develop anemia and neutropenia, but thrombocytopenia is a major one we would watch out for both of the medications. But there are some differences. So for avapritinib, some things to counsel your patient about when starting the medication, in addition to the blood counts, for which we would be monitoring our patients to see their platelet counts specifically. When initially starting therapy, we would counsel them about the risk of edema. So talking to them about some fluid retention or swelling that may occur while they're taking the medication. The big thing as well is nausea and vomiting and diarrhea. So these medications can cause some GI toxicities. It's important that we remember that as providers, because we may not always think of these oral medications as things that can cause toxicities. So providing patients with antiemetics is helpful when you're starting therapy so that they have something that they can take at home, especially with avapritinib. It should be taken on an empty stomach, and sometimes that can be more difficult in terms of causing nausea for patients as opposed to when they're taking something with food, which tends to help the nausea just kind of in general when patients are taking medications. Those are things to discuss with your patient and talking to them about eating maybe smaller meals throughout the day rather than larger meals if they're having nausea, using those antiemetics if they need them. Some patients may even need to take something scheduled like ondansetron prior to their medication each day if they're having significant nausea. Also, the cognitive impairment. So like Ilene was talking about with this second patient, that certainly is a very unique side effect. So patients can have problems with memory or just this brain fog like Ilene described. So it may be something new and may be difficult for the patient to really elucidate what exactly they're feeling, but any sort of confusion or memory changes would be something to let your patients know, to make sure they let their team know about that. Avapritinib, as well as midostaurin, has the possibility to have different drug interactions because of its metabolism. So patients should avoid grapefruits or grapefruit juice while taking the medication. And I will always just tell patients, if you are starting a new medication that a different provider is prescribing to you, to just call us and let us know so that way we can double check there's no interaction with the medication. And same goes with anything over the counter or herbal medications that patients may want to try or take for some reason. It's always best to just double check that there's no interactions. And so the easiest thing to do, I think, is to just have them call us so we can just verify that there's no issues.
So, Caitlin, it was always my perception that the nausea, vomiting, diarrhea is a much bigger issue with midostaurin than avapritinib. Would you agree?
I think overall, midostaurin is more difficult to tolerate, kind of in general. With the nausea and vomiting, patients sometimes report just like muscle pain or other kind of just feeling unwell. So yes, comparing the two, but I just know that many patients kind of when they take their medications, if they're taking a number of medications, they will say that it can be hard to take something on an empty stomach. So, but certainly comparing the two, I think midostaurin is more difficult to tolerate overall.
Something I always like to remind our audiences is that the dose is double of that in AML, just because people are more familiar with the AML dose of midostaurin, which is 50 twice a day. Here it's 100 twice a day. Now, Ilene, do you want to comment on the platelet count issue with avapritinib and how to monitor and all that?
Yeah, and I was going to ask what you recommend for your patients. Obviously, on trial, you're checking labs weekly for the first month, and then it goes to every other month and then monthly. And there was very strict criteria in the trials that if your platelet count went below 100 and then it was 75 about holding and dose reducing. Some patients we've actually used end plate on because we've dose reduced them. Be aware of that and to tell patients, to let you know if they notice any bruising or bleeding because it does drop their platelet count. It can happen at any time. I had a patient who, after 6 months of therapy, came and platelet count dropped to 59, so we had to hold. I think it's clearly something to be mindful of. And I just wanted to comment too, along with the platelets dropping and dealing with brain fog, as a clinician seeing these patients, you always want to be mindful that they're not having a CNS event, such as a bleed versus the side effect of brain fog. And so I think it's important to always, if they have symptoms, to be mindful of a neuro exam, etc.
Absolutely, yes. And just for our audience here, avapritinib does cross the blood-brain barrier and it does impair platelet function. So in the trials, there were some instances of intracranial bleeding, but almost always only if the baseline platelets were less than 50. And that is why it's not supposed to be used in in that population, less than 50 platelets, which you may encounter in advanced SM because many of them could have MDS or CMML or some other AHN that is contributing to that thrombocytopenia. That issue does need to be kept in mind. It's interesting, Ilene, that you say you used romiflostim. I have too in one case. And with regards to monitoring, fortunately, I think the package insert has pretty clear guidelines about the checking the labs and, of course, dose reducing, which was quite common actually in the trials. There was a fair amount of dose reduction, not missed at 200 because of cytopenias.
Majority of my patients are down to 100 or 50. And it's interesting because they're responding and doing quite well at the lower dose level. It seems to be as effective as the higher dose with a little better tolerability.
And in indolent systemic mastocytosis, although that's not our topic today, the dose going forward is only 25. So this is a very active drug with a wide range of therapeutic efficacy with regards to dose.
Exactly. And I think, overall, in my experience, it is very well tolerated from a patient standpoint. As you mentioned, obviously, not taking it with food is a little of an adjustment to people, but especially people that had been on midostaurin seem to tolerate this therapy much better. And I think being that they see a response and it does have less side effects, it makes them, I think, on some level more compliant than the midostaurin patient.
Probably feeling better.
Right.
Right. Median 8 weeks was the time to response, and then they are durable as well. In fact, they deepen over time, as with many targeted therapies. The depth of remission improves over time, but importantly, by 8 weeks, you get, I think that was the median time to response. So I guess switching therapies is an important topic, right? Because midostaurin has been around for 5 years, avapritinib for a little less than a year. So I guess avapritinib, as I was saying earlier, appears to be the more potent drug and would often be frontline. But I'm sure there would also be situations of switching from midostaurin to avapritinib. Do Caitlin or Ilene, do you have any thoughts?
I'm interested what Caitlin says about a washout. When do you stop the midostaurin? How much time do you need to be off the midostaurin before you start the avapritinib is one question that I'd like to throw out there. And then 2, do you recommend tapering the midostaurin versus stopping cold turkey? What are people's experience or thoughts on that?
So from switching to another, I don't think that there would be a need to taper. For avapritinib, like Dr. Bose said, the time to response was 8 weeks, but the drug itself actually is, you reach a peak quickly after you start taking it. And the half-life, both of the medications, is like a day. So it will kind of taper off itself. The midostaurin, by the time it's out of your system, the avapritinib should probably be about at steady state, just based on their half-lives. So I don't see that there would be a need to necessarily taper one versus when starting another one.
Obviously, the trial had washout, like most trials do. But is your thought for if somebody was switching, obviously outside of the clinical trial, that there would be no problem in having a shorter no washout, basically?
Yeah, I would not have a washout unless you're specifically wanting to hold the medication for like a toxicity reason, like thrombocytopenia or something. So maybe you want to let the platelets recover a little bit before you're wanting to reinitiate therapy. If that is the reason that you're switching, or you want to hold therapy and you're also considering switching, then perhaps in that situation it's appropriate to hold therapy altogether if that's what you're considering. But just to switch because of tolerability, like brain fog or something else, that may not be a cross toxicity between the two medications, or because they're not responding to midostaurin, for instance, and you want to do avapritinib, I would not wash out the patient. I would just stop today and then start the new one tomorrow, especially if they're still having symptoms, if this is something that isn't responding to therapy, certainly. But I wouldn't say there was a need for a washout or anything like that.
So, Caitlin, let me just ask you for my clarification. I do a lot of myelofibrosis and how we always taper the ruxolitinib before starting the fedratinib, and the half-lives are different, etc. So, but here you're saying that midostaurin to avapritinib, is it similar half-lives? Because you're saying no need for a washout or taper.
Yeah, the half-lives are similar. Midostaurin has metabolites that have very long half-lives, but the active midostaurin itself is a similar half-life to avapritinib. And unlike ruxolitinib, there is not a situation where if we stop the medication, you get kind of a withdrawal effect.
No, extremely helpful. So this is a different scenario, for practicing oncologists who may be dealing with transitions. That's extremely helpful. On that note, there is another drug that is starting to emerge and perhaps will come into future discussions of switching, and that's called bezuclastinib. This is a drug which is also very potent and selective for mutant KIT like avapritinib, the distinguishing factor being that its penetration of the blood-brain barrier is very limited, giving it the potential for fewer intracranial bleeds and less cognitive toxicity. Of course, we await the data. This is being studied in both advanced and in non-advanced systemic mastocytosis. On that note, there is yet another drug, BLU-263, with very similar properties. So reduced CNS or reduced to no CNS penetration with those exact same advantages if that plays out in clinical practice.
It's very interesting for a non-common disease to potentially have 3 or 4 approved drugs for it.
Absolutely, and non-common is an understatement. Well, thank you both. That will conclude this podcast. Thanks so much for doing this with me.
Thank you. Thank you, everybody.
Thank you very much to our expert panel for that excellent discussion. And thanks to you, the listeners, for joining us. As a reminder, to view the full program, The New Paradigm of Precision Medicine for the Management of Advanced Systemic Mastocytosis, from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.